My name's Taylor. I'm one of the co-leads for RPIW number 38. This is essentially our agenda. We'll be speaking with you for the next 20 minutes in this order. Here's a picture of our fabulous team. Again, like others have said, I can't say enough about this group of people. We're missing Corey today. The rest of us are here and they'll be introducing themselves. I'd especially like to thank you, Claudia, and thank you, Lorraine, our patient and family advisors. They brought, I heard Lorraine say, if you don't mind quoting you, I'm not sure if I made a difference. And I can tell you unequivocally, yes, you've made a huge difference. Your insights and how you kept us on track and how you made this truly meaningful in your honor. You did a great job, and for those you represented, so thank you. Now I wrote it down because they say I talked too much, so I'm going to read it. So who is this team? Well, they were charged with developing a goal-oriented process for individual mental health outpatient counseling, one that includes the termination phase of the therapy, which we've learned from best practices is very important. The theme of this RPIW is quality, client access to mental health services, the right service, right time, the right place. So why was this chosen? We'll look to our value stream map. You can see that the lead time along the bottom there, from when an adult, we were looking at adult chronically mentally ill folks, when those people entered at the initial assessment intake access point there, to the point where they have essentially gone off service, if you will, is, well, it's very long. What you'll see is 32,000 hours there at the bottom. And of course, Paul and I didn't observe that. That was something we took retrospectively. The wait times are pieces where a client would be actually waiting for the appointment. The off-service, however, is where a client is well enough to be well and is not needing service, if you will. So because of this off-service piece, you'll see that the value add percentage is a bit skewed. It's less than a percent. So during our prep time, we had a chance to talk to many of you. Many of you are here right now, so thank you for coming. We learned about your work. Thank you for showing us and helping us understand it better. Clearly a really dedicated group of individuals, no doubt. What they described as they being those providers of care, they described that along this value stream, what often happen is that they wouldn't technically discharge some of their clients because they would then have to start from the beginning and go back through that process. So that was something that they identified as an idea for improvement. Is there a way that we could have a re-entry point into the system should someone relapse again? They also identified those fine providers of service, a lot of wastes that we could look at. And we sort of ended up theming them into client education, access and flow, standard work, and paper flow. So within the mental health outpatient system, that tack time, essentially when you need to get somebody out so you can get somebody back in that access way, is 90 minutes. So we observed not only the flow of the patients, which is probably too long to see outcome measures change this week, although we anticipate seeing those change over time in the audit because of processes implemented this week that we will track. We also observed clinician flow, and we saw a lot of variation. What I'll show you next up here is in a 3-hour time period, the variation in what clinicians' work may look like and where that's being spent. At the next slide, you'll also be able to say that daily clinician workflow observed over a 2-week period when they did self-follows, which is a lot of work, so good on them. And you can also see a lot of variation there for opportunities for improvement. So after looking at the patient flow and the clinician flow, it was ultimately concluded by all the good people in the area and this team that the focus, the purpose would be of this RPIW. Clients are empowered to leave care and have a safety plan with knowledge for how to re-engage should they need to. So while the target sheet isn't maybe as conducive to this kind of long-term outcome measure, there are some things that we thought we could track within this 3-day period. We looked at the walking distance of the clinicians and their flow. We also looked at some quality measures. Are there service agreements in place? Is there a transition plan in place? Is there that education piece there with that? And we also looked at a 5S. I'll now pass that on to that section.
Hello everyone, my name is Paul Ross. I'm with the Health Inspection Department here at the Health Region. So we took on a 5S project. There was a treatment room which was converted into a storage room. And so these are the pre-pictures of the storage room, and the goal was to open it up, clear it out so that it would be available for treatment by the clinicians. So there's a number of items: chairs, boxes, old office files, references, old enema kits. There was lots of them. So,
From 1966.
yeah, so there was a lot of dated items in there. The score of the 5S on the pre-side was a 1, so we had lots of room for improvement. And here's some photos after the 5S process. So we were able to fill a dumpster half full of paper, and so this is the clinician area, the treatment area, and also the storage area. And so there's a photo here because our process owner snuck a shelf in there to use it as a resource storage room now. So we've got good practical use of this area now. And our score changed from a 1, so we were scored at a 3, so we saw lots of improvement. Okay. So again, our purpose for this RPIW is, we want to ensure that our clients are empowered to leave care and have a safety plan with knowledge of how to re-engage should they need.
No.
Oh, sorry.
That's okay, you
Jumping
just
gun.
read out what was in part of my shtick here. So this is sort of the problem that was identified, is we needed a great way for people who left our care so they can re-enter in a timely manner when they need it, not 2 months down the road when the crisis has gotten really significant. So with the assistance of Lorraine and Claudia, our client and family representatives were able to generate ideas to address some of these concerns. So some pictures up there. We wanted to, number one, have a procedure for the client to have the knowledge of what to expect throughout the counseling experience. So we begin, we have a middle, and we have an end, but we also have a way for them to enter. Number two, for the client to have a safety plan in place when counseling services end. 3, for the client to be educated on how to re-engage in services if needed. 4, for the counselors to have appointment spots open for the returning client to assess their needs. And 5, that the client will have a list of community resources and emergency services to refer to after counseling has ended. And to have the information written for the client to refer to when it is necessary. Our focus then changed to working on ways to solve the problem. We created 5 new work standards and 4 new forms to address the purpose of this RPIW. At this time, we are testing both the service agreements and changing services plan, and we are gathering feedback from both the clients and the counselors, and Karen will explain in more detail. Karen?
Thanks. I'm Karen Mason, and I work as a Northern Consultation role, and I also work on the Knowledge Exchange and Implementation team, and a lot of people laugh at that very long, convoluted title, but that's what I do. So what we're going to talk about are the ideas that Catherine talked about, how we turn that into work that we can accomplish. So the first thing that we did is we created the Client Services Agreement, and this is used when our clients enter into our service, and it makes the client's goals central and supports treatment planning throughout the process. It also helps us to talk about the limits of confidentiality with our client and make sure that some of those important pieces of work are being done consistently in a standardized way. The second piece of the work that we did is the Changing Services Plan. Okay. The Changing Services Plan. So this is happening when a client no longer receives individualized intensive services. So what it does is it identifies the other services in the community and other places that clients may still be accessing services and getting supports. It talks about the social supports that they have, identifies some of their skills and strategies that clients have used in the past to help maintain their wellness, and that's something they can take with them to refer back to. That's something that we heard was very helpful. And it includes a part of a safety plan, and it lists services that are available in the community, provides that education about where they can get supports, and how to re-engage with us should it be necessary, what that process will look like for them. And this one piece of paper will also serve as the termination note in the clinician's notes. The third piece was contemporaneous closing of files. So it details when a file is to be closed, when the file is to be terminated, and it facilitates that same day closure of files, as opposed to holding on to them and waiting and then doing them in 6-month chunks. And we see this as useful to supporting the clinical supervision process and the auditing pieces that are available. And the fourth piece is that we created the relapse prevention single session appointment. So with this, clients are able to, if they need to, they can return to us in a timely way and receive services when they need it and not months from now. And the idea is that ideally, the person returning to service is able to return to the clinician with whom they have a relationship, who knows how to support that person with their individualized needs. That one appointment time will be used to assess what's needed, provide supports, services. If they were to require more services beyond that, they would be provided with a new appointment slot. And work standards and multi-skills training sheets have been created. So we've done a good piece of that preparation for implementation piece, and then we'll hand it off.
Good afternoon, I'm Kathy Iverson, the Assistant Director of Long-Term Care in the region. And I was part of the team that looked at addressing client access, increasing client access to the department, and increasing the amount of available time to counselors for direct patient care. So one of the concerns that was identified were counselors were spending a lot of time and a lot of walking distance going to the waiting room to check to see if their patient was there. And the MOAs were spending a lot of time and making multiple phone calls to the counselors to say, your patient is here. So we started to generate some ideas about how we could address that. An add-on alert system that could be a one-time notification. But we took that out to the staff, and the staff said Vocera would help us tremendously. They felt it would cut the amount of time in half that they would spend searching for someone and be able to effectively communicate with those they needed to in the department. And the staff were very excited and enthusiastic about that. They had staff that have utilized Vocera before. So we started to explore the possibility of testing Vocera in the department, only to find that the wireless capabilities in the department required enhancement. So we couldn't move forward with some testing during this RPIW. But not to lose the great idea that the staff had, it was suggested that a business plan could be developed using the results from our RPIW that could be put forth to senior management for consideration and approval of Vocera implementation in mental health. But what we were able to do to test that one-time notification, we used cell phones. So we were able to get 5 cell phones from client access. We left one with the MOA at her desk, and we gave one to each of 4 counselors that were agreeable to test during the days that we did. So the idea was that the counselor kept the phone on them, so no matter where they were in the department, they would receive the text or that notification and feel the vibration that they knew their next patient was there. So we did create some standard work, I think too, through there, we did create some standard work about the counselor responding to that notification, and we initiated that training schedule to go along with that. So the results or the achievements that we were able to see with using the cell phone test, previously it was a counselor was making 4 trips back and forth to the waiting area for a total walking distance of 114 feet. And after using the cell phones, they were making 1 trip with a reduction in walking distance of 22 to 22.5 feet. So we saw an 80% reduction. And with the hope that it would free up time for more direct patient care.
Hey everyone, I'm Adam Pearson, Nursing Unit Manager of Mental Health Inpatients, and I was also a part of Kathy's team, but focused more on the client experience as they access services at Mental Health Outpatient. So when we did our waste walk, we recognized a few improvement places, and one was the lack of signage that could be deemed appropriate or really guiding the client down to the outpatient services. We also heard some concern around the variation that a client may be registered. There's anecdotes that a client would come down and wait for the clinician to register them, that walk-in clients would arrive, perhaps not knowing they had to check in and then leave without receiving services. So we had a few ideas. The first solution was to put up some temporary signage to better direct the client on what is expected of them. And the second is to create a number system or a pull system to better control the flow of clients at client registration. So what we did, if we go to the next one here, is create another signage asking the client to take a number. They take a number and they have a seat. The MOA then would call that number. They would come up to the registration desk, be registered. The client would go back and sit down. The MOA would call the next client. So this increases confidentiality, decreases that queue in the lineup, and also gives the client something tangible to recognize that they're in the service now and they will be addressed going forward. We timed the processes both pre-implementation and post, and while there wasn't a dramatic shift or change in the waiting times, we did feel that the increase in confidentiality made this change valid. We trained the MOAs. They feel that they can better control the flow, and we have the work standard and multiple skill training checklists that are completed.
Sorry guys, I kind of got flustered there and dove into the first empty chair I saw. Okay. Okay, so on the first day, as we're probably all of us are aware, the waste walk happens on Monday. So this is our waste wheel with all the different categories of wastes, and these are the improvements that we achieved through our processes and our findings for the week. This is our post-value stream map, and unfortunately we weren't able to really do any assessments on the times. However, due to the areas that we were able to address, and by no means we don't consider them fixed, but we certainly found some areas and were able to address areas in terms of standard work for counselors, for doing admissions for their service agreements and for their end of service agreements, patient education. So there was a lot of success found in our processes, and we hope that, hold on. So we also hope that during our process in our future audits that we're going to be seeing increases, or decreases, I'm sorry, in this off-service time because of that extra loop for a follow-up that has been created in this, for the standard work that we've created. Okay, thank you. Our post-target progress report, we saw some increases in our 5S areas in terms of our spacing and our inventory. We didn't really do much with inventory. Our walking distance for the clinicians, we saw some increase in that, or some betterment. And then we're just running tests in terms of the service agreements and also the termination of the end of service plans. So those tests are going on right now, so we've seen some improvements in those areas as well. Looking at our newspaper, we have a number of items that have been addressed based on the standard work documents that have been created. And we have a couple of areas in terms of long-term caseloads and also a standard client educational resource binder or filing cabinet for the process owner to address in the future work. So we have some hand on that. So in summary, our workshop has created and tested tools to facilitate solutions to problems that were identified. PSDA, the information flow, created framework for quality processes, and throughout the whole process we remain client-centered throughout. So thanks, Claudia and Lorraine for that. And we have some thank yous. So we'd like to thank all of our team members. Oh, I'm sorry. There I go again. Lorraine, would you like to join us?
My name is Lorraine Booker. As a client, this week has opened my eyes and made me appreciate of the endless time and the hard work that is put in to help every client. I will call you caregivers because you care and you give so much to the client. I'm glad you are not farmers. When a chicken is unwell, we just cut their heads. When clients are unwell, you don't just put a Band-Aid on our head. You are caregivers, are also counselors, teachers, and road runners. You give us tools and teach us to use them, and let us know there are helpful community resources that we also turn to for help. And mine right now is group and psychiatry.